Hi, welcome back to ParentingU. I'm Stephanie, and today we're talking with Dr. Kenneth Habetz, pediatric neurologist with Our Lady of Lourdes Women's and Children's in Lafayette. Welcome, Dr. Habetz.
Thank you.
We're talking all things the brain today, seizures, epilepsy. As a pediatric neurologist, tell us about your training, where you've come from, and what do you do?
I went into college not expecting to do medicine at all. That's all I knew for sure is I wasn't going to be a doctor because everyone told me you have to go be a doctor because I made good grades in my school. Like that was kind of the
Mm-hmm.
point. So once I got into medicine, interested in medicine, I wanted to do pediatrics, general pediatrics. I wanted to go in a general pediatric clinic in Lake Charles or somewhere small and do that. That's what I wanted to do. But in med school, I got really interested in neurology academically. And once I learned I could do that with kids, then that was it, right? That was it. So I went to Little Rock, where you do the way a pediatric neurology training works. You do 2 years of pediatrics, then you do 1 year of just adult neurology. So like stroke service, neuro ICU, all those kind of things. Then you come back and do pediatric neurology. So you do all those. And then I did a year of epilepsy fellowship afterward, right? So it's pediatric neurology residency with an epilepsy fellowship.
Yeah. So it's like even extra focus, extra time,
Extra focus, yeah.
extra attention
You got it.
to that specific thing. Well, and tell me a little bit about why you chose to come back to Louisiana, because especially a specialty like that is so needed, especially in our kind of rural communities. So tell me about that.
Yeah, that's an easy answer. I'm an LSU grad and I'm obsessed. And I grew up on a farm and my parents are never moving anywhere ever. And so moving back to Lafayette, I'm able to, which is the closest place to Ragley, Louisiana, that I could do this job. Okay. And so that gives me the speed to which I can attend baptisms, Christmas parties, and I'm not going to say more importantly, but you understand, watch LSU games
Get it?
together.
As a fellow alum, I get it.
So that allows me to do, I mean, the family's huge and
Yeah.
there's always something to do. And being in Little Rock, I wasn't able to attend all those things. And
Sure.
now I am. So there was some fringe benefits of moving back that I wasn't expecting. You know, I'd never been to Lafayette before, but being back in Louisiana has been interesting, especially seeing patients who are from where I'm from. And I think there's a lot of cultural connection that I didn't have necessarily even in Little Rock. It's not that far, but it is very far compared
Yeah.
to South Louisiana.
Yeah.
And so I have no plans on going anywhere else.
Well, I know that the network and the patients are glad you're here because neurology and this specific field is so needed.
Yeah, I think that a lot of patients when I first came to Lafayette hadn't seen a neurologist in 5, 6 years because they didn't want to drive across the Atchafalaya or anywhere else, you know. So they had seen a neurologist and they didn't have one. And so the patient population it was surprising to me how many of them had just kind of gone without care for a long time.
Mhm. So why don't you start with the basics of seizures? Where do they come from? What are the signs and maybe the different types?
There's a lot of things that look like seizures but aren't, so it's very confusing. It's very scary, and so the way you define a seizure is it's abnormal electrical activity in the brain that then correlates with some sort of clinical change, right?
Okay.
So as a layperson, or if you're just sitting like this, you won't see the electrical discharges, right? So you're left with the clinical change.
Mhm.
And I think the classic most people are familiar with are so-called grand mal seizures or generalized tonic-clonic seizures, the large, I call them TV seizures for families who are trying to decide what they're seeing.
Mhm.
But some sort of abnormal movement with an abnormal mental state, right? So some sort of confusion or change in personality, and it ranges all the way from very overt, frightening, scary ones to kind of more subtle things you may not think of as seizures.
Mhm.
But medically speaking, the way you define that is the electrical discharge that then correlates with a clinical change.
What's an example of that?
Jerking is kind of the more common thing you would think of.
Mhm.
That looks like they stiffen up, they fall out, even something subtle like eye twitching or facial twitching. And so I generally simplify it when I talk to patients and say any recurrent, unusual thing that looks the same every time should be investigated, right? I think that's seizures don't typically migrate. You don't have 50 types of seizure in one person. So anything that I think is recurrently odd is something that needs to be investigated.
Mhm. Well, and you mentioned grand mal. What are some other types of seizures? I know as a parent, I've heard of febrile seizures. Like, talk us through kind of the
Yeah.
levels of those.
So, but we'll start with febrile seizure,
Yeah.
right? So a febrile seizure is usually a generalized convulsive seizure.
Mhm.
It looks just like a grand mal seizure, generalized tonic-clonic seizure. They change the terminology every few years, but we'll leave these. I think most people are familiar with
Mhm.
them. And a febrile seizure is just a type of seizure that appears between 6 months and 6 years old,
Okay.
provoked by fever, right? It looks the same as any other type of seizure. It just, in that population, in that setting, it's a different category to where it's not epilepsy. You don't have to be on medication. Most people grow out of it.
And is it the level of fever? Is it the range of fever? Like, what triggers it?
There's a debate about
Oh.
what triggers it. I think what most people tell people when they discharge them is that it's the rate of rise of fever. I don't know that to be true.
Okay.
The criteria we use is it fever, right? As long as it's fever, it counts.
Got it.
And so no one knows why some children are vulnerable to those and others aren't,
Mhm.
right? And there's different categories of febrile seizures. There's simple febrile and complex febrile, and they're defined by how the seizure looks, what type of person had the seizure, and how long they are. Oh, and also how many,
Mhm.
right? So if you have more than one in a day, it's complex. If it's more than 15 minutes, it's complex. If only one part of your body moves, it's complex, which is exact opposite. My parents, when they come in and I say, well, it was a generalized seizure, so that's good. They're thinking, well, I kind of would rather just one part of me sees than all of me sees, but it's better prognosis if you have a generalized
Got
convulsion.
it. Got it. What else should parents know about seizures? Are there any ways to prevent them? Are there things to look out
Sure.
for?
So I think that the first thing a parent wants to know with a seizure is what to do when one happens, right?
Yes.
What do I do? And I keep it real simple. Put them on their side, don't put anything in their mouth.
Okay.
That's it. That's my summary. I also usually send people to epilepsy.com, which is the Epilepsy Foundation's website. There's a simple one-page printout as to what to do.
Mhm.
You can get more complicated as people are more familiar with seizures, but my experience is for the first several seizures and hopefully forever, you're not comfortable with that. You don't want to have enough to be comfortable necessarily.
Right.
So put them on their side, nothing in the mouth.
Mhm.
In terms of preventing seizures, I would argue there's no real way to prevent them because you don't know who's going to have them until they have them.
Yeah.
And once they have them, there are things you can do for children with epilepsy or children with recurrent seizure disorders.
Mhm.
Things like making sure their stress level's okay, their nutrition's okay, all the things you're supposed to do anyway, but in particular, focus on sleep. You don't want to have sleep deprivation. You want to avoid illness where possible, which in today's world, daycare, schools,
Mhm.
grocery
Yeah.
stores, I don't know how you're going to do it
Yeah.
realistically, but sleep. And then if someone has prescribed you medication, never miss,
Mhm.
right? Because the most common cause in my world of breakthrough seizures, once we've had you controlled,
Mhm.
is we got a little too complacent. We got too comfortable with the control and we started missing our medication.
Mhm. So let's say my child has maybe had one seizure. We've gotten it checked out. When does it get to a point where we're starting to worry or that maybe we're starting to think, "Oh, this could be something else?" What are those signs, and then what could it work up to?
If you end up seeing one of us in neurology, depending on your scenario, we'll probably do some tests.
Mhm.
EEG would be one test,
Mhm.
which it's similar to an EKG. Everyone sees EKGs on TV all the time, right? Except we put stickers on the head and we put a bunch of them.
Mhm.
And then we read your brain waves and see what they look like. Okay. So a first time seizure in a person with no medical problems may not even get the EEG, may not get any imaging, may not get any testing at all. I tend to do EEGs on them, and if their EEG fits with an epilepsy syndrome or points to an increased risk of having another one,
Mhm.
then we give the diagnosis of epilepsy even with one seizure and we start medication.
Okay.
So you should be evaluated for the first seizure, I think.
Mhm.
For the second seizure, you
Absolutely.
yes, have been needing to, right?
Mhm.
Have been needing to be evaluated. And so there are also children who maybe they're born like we're on the fourth floor here, the NICU here.
Mhm.
So some preterm children who've had brain injury, the doctors may tell them in the NICU, you're at increased chance of having a seizure. And some of those children, even with their first one, would then need medication because they were already at higher risk, right? From being preterm or having cerebral
Mhm.
palsy or whatever reason. So I think the time to worry is whenever you're worried is okay
Mhm.
to worry, right? I think first step is talk to your doctor and say, "Is this something I should worry about?"
Mhm.
And then next step is they can call us. I mean, I'm sure the Baton Rouge folks have the same rules I do, which is they can call us and we can recommend workup and take care of that immediately. But I think the first time seizure is time for some evaluation. A second time seizure is as warrants probably treatment.
Mhm.
Right.
Mhm. Well, talk to me a little bit about epilepsy. So you hear that word. Is it just recurrent seizures or is there more to it than that?
Sure. So epilepsy is defined, the way I tell parents is epilepsy is when you've had a seizure and I think you're going to have more if I don't put you on medication.
Mm, yeah.
And so that's kind of the shortest answer. You won't find that on a website because I don't think it's too exact, but if it implies, I don't think this was a one off. I don't think it was because you were too hot. I don't think it was because the lights flickered in school. I don't, any of the things you think of when you're trying to talk yourself out of saying, I've got this new serious diagnosis. But the definition is two seizures without being provoked, right? So, for example, if you have diabetes and your glucose ranges and makes you seize, you can have several seizures because of the glucose and it's not epilepsy.
I
It's just your body's natural response to that glucose problem.
right.
Whereas epilepsy kind of generates itself, right? Your brain is generating your seizures at that time. And so medication is used to diminish your chance of breakthrough seizures
Mm,
until we get to the point, if ever, where you're at less risk and we can take you off medication. So,
mm,
two seizures separated by 24 hours with no reason, one seizure with an underlying diagnosis that predisposes you to more seizures,
mm,
or one seizure with an EEG that looks like the same,
mhm,
right? So there's several different ways to get into that diagnostic category. I try not to rush into it because once we start medication, this is a long-term treatment.
mm,
Most of us treat at minimum 2 years once we start you on medication. So we try to stick to landing, be very certain about the diagnosis. And sometimes it's hard. No one saw the seizure, for example, or you're not too sure because it was 3 in the morning and you were freaked out and you're not exactly certain what happened. And so you really want to try to tease that out with an interview.
mhm. For the parents who maybe have kids who are living with epilepsy, what does that look like? What does life with epilepsy look like? I mean, I would think it would be pretty normal childhood with some medicine, but
Yeah.
are there other things that
So
could be
exactly. The goal is that.
Mhm,
That is the goal. But then there's the psychological and stressful component. Like I can tell you, well, just do your thing. Don't worry
mhm,
about it. And then you say, well, what's the worst that could happen? And
yeah,
severe things can happen. Or,
mm,
well, how do I know he's not going to have a seizure? Well, you don't. Right. And so even though you're in your normal life, they're on medication, they're not seizing, playing sports, whatever's going on, if you're going through a grocery store, could have a seizure. So I think a lot of parents have that in the back of their mind all the time. And
yeah,
the disease burden in pediatric epilepsy to me is that worry.
sure.
So if you have two seizures, they're 30 seconds apiece. You're 8. You've had 1 minute of seizure in your life. But now every minute is dominated by that fear that the next one comes,
Wow,
right?
you don't think of it that way. That's
No,
incredible.
because parents will call you and you can hear it in their voice. You hear it over time that they're just worried and worried and worried. And when you go back and look at the chart, you're like, you've had 2 minutes, 3 minutes, 4 minutes of seizure ever. You're 15 now,
Yeah,
but still getting learner's permit,
mhm.
going camping, going with some cousins out to wherever we go in Louisiana, right? And so you have these kind of fears. And I think that
Mm,
it's legitimate. There are ways to mitigate that, but I don't know that there are ways to eliminate it.
yeah.
Yeah.
But understanding the facts, I think could help.
Yes.
That just it's been a minute of your life
And a plan,
and a
right?
plan.
And a plan. So if you're like me, I'm very uptight about plans. I like to have contingencies. I like to have all these things. And I think that for people like me who are anxious people who kind of ruminate, having plans and backups are very important,
Mhm.
right? So in our patients, we give rescue medications in case a seizure goes too long. There's something else you can have besides your daily medicine, like an EpiPen or an albuterol inhaler for epilepsy.
Yeah.
They now make a nose spray for that
Mhm.
purpose. And it gives people, especially in my population, very rural population, traveling from all over the state, they may not be near a hospital. They don't know how fast someone can get to them. So having that confidence at home is important. Having a way to monitor the patient during nighttime. Imagine trying to sleep. You're already, this is your first child. You're already scared of them in the room by themselves. Every time you hear a noise, you get up and run in there. But now you have the
What are you
same
talking
thing.
about? No one does
Yeah.
that.
Okay. Sure.
You're
So
so right,
it,
though.
and so they make wearables,
Yeah.
baby monitors with cameras now. There's a lot of avenues to eliminate some of those fears, but it's
Mhm.
difficult to try to encourage people, okay, do all these things which sound a little obsessive, but
Mhm.
also calm down and just live your
Yeah.
life. And so I think everyone has a balance that they end up enacting. My experience is one parent is one way and one is the other way. One
Mm.
pretends it's not there and one only thinks of it all the time. That's all they do.
Tell me about what a parent should do if they think their child is having a seizure.
So the first thing to do when you think your child's having a seizure is put them on their side. Don't put anything in their mouth.
Okay.
If you're not sure of any of that, you should just call 911 and then do what I said, right? So they can come and handle whatever emergency is there because panic is normal in that setting. Panic is normal in the hospital in that setting. So as a parent, It's so common for all thoughts to go out of the window. So call a trained personnel whose child it's not their
Mhm.
child
Yeah.
who can come and handle that. So I don't know that 911 calls are always recommended for first time seizures, but I would because why is the seizure happening? You have no clue. The history begins at that moment. So there's no way to know, is this diabetes? Is this meningitis? Is this anything? You have no idea.
Mhm.
Once you have a diagnosis of a seizure disorder, then you don't always have to call an ambulance. But I think for the first time convulsive seizure, someone professional should see the kid soon and evaluate them for anything more scary than a seizure.
Mhm. What are the types of treatments for seizures, all the way from maybe just better sleep to is there surgery? Tell
Yes.
me the range.
So there's a big range, and the treatment pathway in kids is a little different than adults because it's not all approved here. But so the first treatment for me is rescue medication. If you may have another one, but we don't know if you will, you don't have a diagnosis of epilepsy. I do tend to give rescue medicine for someone who has demonstrated that they can have a seizure. They have had one.
Mhm.
That's not standard practice for everybody, but I do think it's helpful for parents to have something they can do because I'm telling them this may happen again. We don't
Sure.
know. If you have a diagnosis of epilepsy and it's almost certainly going to happen again, then I'll want daily medicine.
Mhm.
Of those, there's, let's say, dozens. It's probably close to 30 something
Mhm.
different med options. And we choose those based on your age, if you can take a pill or if you have to have a liquid. How rural your community is not really a big issue because the network has gotten pretty good where the meds are out there.
Mhm.
Insurance shouldn't matter in terms of choosing medication, but the type of seizure, the age, and what you can do. So if your child takes medications with a G tube or their mouth or they're finicky about liquids and they only want chewables, so that dictates some of this, right? And the EG findings, right? So the type of seizure that you described to me, the one that you video, hopefully, that's
Mhm.
we'll talk about that in a second,
Okay.
right? So the one benefit of having cell phones attached to everybody's body all the time is that we can get video of this. So you don't have to try to go back in your fear-ridden brain and remember everything that happened,
Mhm.
right? Because the things you noticed are big, scary things. But sometimes the more important parts are these little subtle details
Mhm.
at the very beginning of the episode. And so the video is helpful for us, but your first time seizure, you won't. So the way the seizure looks, how the child can take medication determines which ones we choose. So let's say you're on medicine. It was the right medicine. You made it to the right dose. You didn't, have a side effect or a problem and you failed.
And when you say fail, you mean the medicine just doesn't work right.
That's correct. Yeah, I guess failed's kind of a negative term, right? But it means that the medicine didn't do what we thought. Or you had too many side effects to where we didn't get a chance to get to the dose that I thought was going to work. Either one of those would count as failure. So a certain percent of people do that,
Mhm.
but most people do respond to their first medicine.
Mhm.
Then you try another one. Again, that has to be fitted to your everything.
Mhm.
Once you fail those two, then we usually look for non-medicine options.
Mhm.
And some parents say, well, I want those first. I want the non-medicine option first, but non-medicine in seizures is not natural
Yeah.
either, right? It's not just totally benign. So there's the ketogenic diet, which is not the magazine ketogenic diet. It's not the current keto craze.
Yeah.
It is a hardcore, serious ketogenic diet, which is usually initiated inpatient. Think about it like a type 1 diabetic diet where you're counting everything, you're monitoring everything, you're talking to a nutritionist, they're checking your blood levels, because almost all of your calories have to come from fat to do the ketogenic diet.
Oh, interesting.
So
Is that because the food tell me why that is?
I thought you were about to ask me a question everyone asks, which is, does sugar cause seizures? And so
Oh.
that's what I thought they'd go to. So the ketone bodies are anti-seizure substances. So
Okay.
think of them as like a ketone is anti-convulsant. Okay.
Okay.
So in the old days, like biblical old,
Mhm.
fasting, starvation were seizure treatments. Not just for
Mm.
the evil spirit connotation that they had at the time for epilepsy, which is kind
Sure.
of what they thought,
Sure.
but the actual ketone bodies generated by fasting would be anticonvulsant, right?
What's a ketone body?
So it is let's call it a byproduct of a different type of metabolism. So right now you use sugar for energy.
Okay.
In the ketogenic diet, they used ketones for energy.
Okay.
And those ketones float around and are anti-seizure.
And ketones are found in food.
Ketones are made from you when you eat certain foods. Your
Got it.
body prefers glucose and sugar, right? If you don't have that, it'll do this. But part of the reason you have to do inpatient is not everyone does that transition like they're supposed to.
Sure.
So then it's not safe for you to be on the keto
Mhm.
diet. So they have to monitor you for that purpose. It's very complicated, I guess, but the ketones from a ketogenic diet are more likely to cause seizure reduction than a third or a fourth or a fifth or a sixth medication, which is why you start looking at some of these other modalities.
Does sugar cause seizures?
No.
Tell me why not.
Oh, I don't know why not. I like sugar, so I'm not gonna
Is that a
besmirch
myth?
sugar.
Is that a myth that's out there?
I think that when you tell people about the keto diet, the concept is that the carbohydrates or sugar is what caused the seizure as opposed to the ketone, which
Gotcha.
requires no sugar to be made, is anti-seizure. That makes
Gotcha.
sense?
Yeah.
So let's talk about other treatments.
Yeah.
There's a VNS, which to the naked eye looks sort of like a pacemaker. It's like a little box, right, with a battery, and it stimulates your vagus nerve,
Okay.
and that reduces the amount of seizures. So that's another thing that we do. And then there's surgeries. So epilepsy surgery, very complicated
Yeah.
because you don't do that first line because it's surgery.
Mhm.
So the criteria for an epilepsy surgery would be you've not responded to treatment. The doctors have tested you a lot.
Yeah.
They have found out where your seizures are coming from,
Mhm.
what that part of the brain is doing, and can it be safely removed?
The part of the brain
Correct.
they safely removed?
Yes.
Oh,
And so this is brain surgery that
yeah.
epilepsy surgery is, right? So you take the epileptogenic zone that, let's say, causes the seizure and you
Mhm.
remove it and
Mm.
the seizures stop. So there is a certain degree of seizure freedom forever from that.
Sure.
But there's a lot of networks that are created at the time of a seizure. And sometimes you think a seizure comes from an area and it may be somewhere else. So there's lots of testing that has to happen,
Mhm.
including even EEGs on the surface of the brain,
Yay.
which is another surgery, right? That you do to stage this and plan this. Obviously, you don't want to do this surgery if you don't have a reasonable chance of being seizure free.
And so I'll go back to something you said. Seizures can be caused from different parts of the brain. They don't all come from the same place.
Correct. So sometimes the seizure comes from everywhere.
Mhm.
And I think over time, less and less seizures are thought to be so-called generalized seizures.
Yeah.
So in a generalized epilepsy, usually you don't do surgery because how do you remove the whole brain? You
Do
can't
it.
really do that,
Can't
right?
do it.
Not very safe. So those are usually genetic or you grow into seizures. Think of absence epilepsy, which is sort of a staring epilepsy. Have you ever heard of absence? So
Mm-mm. Mm-mm.
it is a staring epilepsy, and literally it's just 5-10 seconds of a pause. Can be longer than that, shorter than that. So a lot of schools, a lot of parents whose kids have ADHD or other things start thinking about this type of epilepsy, but it's a generalized
Okay.
epilepsy. So that would be the surgeries. In adults, there's actually an implantable you put on the brain,
Mm.
which has got 2 EEGs, maybe more now, of leads that read your brain waves. And when it detects a seizure onset, it kind of resets.
Mhm.
It resets
So it
that.
kinda starts it before it
Yeah,
stops it
stops
before it
it before
starts.
it starts. Yeah. I don't know that they're doing those in pediatrics. And I think some of that has to do with real estate in the brain,
Yeah.
right? There's 2 brains are growing and you're
Yeah.
putting stuff inside there. So
So that's right. I had no idea that it was so layered and nuanced and
yeah,
just different ways that and different approaches, and it just makes me more grateful that we have people like you
thank you.
that,
But epilepsy surgery is such a big conversation. There's whole conferences, weeks of it, which is different types of epilepsy surgeries, different
Mhm.
strategies, because everyone has an opinion, large removals, small removals.
Mhm.
And then there's even times where they'll remove a whole hemisphere.
Mhm.
But it depends on your underlying diagnosis. Let's say, for example, you have cerebral palsy
Mhm.
and an injury that makes you not be able to move an arm. And that injured part of your brain's now making you seize. It's not moving your arm because it's injured, but it is making seizures. So your good side is functioning less because you're having all these seizures
Yeah.
because of this injury. And so the removal actually improves your mentation. It improves your function, which isn't an easy pill to swallow when you're told we're going to have this brain surgery and it's going to make things better
Yeah.
because it's just hard to
Yeah.
fathom.
For the majority of the parents listening now, they'll probably never have to get to that point. So is there anything else that you'd like to tell parents just about if they experience a seizure, if their child, if they're worried, what else can
Let's
you
give
tell
good
them?
numbers. We'll give good numbers
I
this
like
time,
that.
right? So most people who have a first time seizure do not have any more.
Got it.
Most people who have epilepsy grow out of epilepsy. By people, I'm defining that in my people,
Sure.
pediatrics.
Yes.
There are subsets that aren't true. It's not true if you're a grown up or an older person. But in pediatrics, just like you grew into the problem, which is usually a question, why would this start at 5 if I was born with this risk,
Yeah.
right? So your brain changes all the time.
Yeah.
And your brain kind of walks into this risky phase where the electricity is now not being regulated. Seizures are happening. We've given you medications to prevent those during that window of vulnerability, then as you grow out of it, we take the medicine away, right?
Mhm.
And so most people grow out of seizures. Most people are controlled on medications who have seizures.
Mhm.
So I think that's kind of the take home because you think of things like epilepsy means I'm going to have this forever.
Forever.
Epilepsy means I'm going to seize all the time.
Yeah.
So then they don't call me because they expect a seizure to happen. So they don't notify me. So I can't change their medications because my goal is no medicines, no seizures, no side effects to medicine, and everything normal.
Mm.
That's what I want.
Yeah.
So
Well, I'm gonna go back to one other thing you mentioned about filming a seizure.
mhm.
So if you've for as a parent, if my child has already had one, maybe I'm a little bit more attuned. Obviously, I'm not going to film it in the moment because I'm freaking out. But if you know or have the way of mind to think of filming it, tell me about that.
Yeah. So what I've done, and this has been a little more successful, is if you're in a family unit, close knit family unit, everyone has a task.
Mm,
I'm the one who's going to put them on the side. You're the one who's going to film. You're the one who's going to do this, just like they say for fire drills or any of these other
yeah.
things. Everyone has a task. The main thing to remember when you film is to show everything, the whole body. Don't zoom in too much and look at the thing, right? Show everything and take the covers off.
Mm,
Because sometimes you're,
mhm.
just like you said, just like you're panicking. We have this family story. My grandma went to see the Blue Angels, and she's filming this plane, and all the camera shows is the sky. And then every once in a while, you'll see a plane cross it, right, while she's looking for this. And that's how it happens when you're scared, right? But I think that baby monitors with auto recording is helpful
Mm,
because they exist. You don't have to film anything; it films it for you, and you just give me the video. Um, but cell phone footage is helpful. You want to see the face, especially, and the arms, right? And so I think it's helpful because parents get tired of telling their family members what happened, the ER what happened, the admitting doctor what happened, me what happened, and eventually they're just like, I'm tired of reliving this over and over and over.
mhm.
And if they have the film, most people don't like watching those films, right? They're
Yeah.
kind of frightening. Even physicians, it's not their child, but
Yeah.
I think it's very important because there's no way to be misunderstood with the video, right? And so sometimes we make decisions based on what we think you're saying, and that's not what you're meaning to say,
Yeah.
or not even what you said,
Right.
right? And so I think video cuts through that.
Well, I think that's an incredible tool for parents to think about, to have the presence of mind to use in the toolbox of all the things to help their kid if they are living with seizures or going through this experience.
I encourage it, especially for a seizure type that doesn't fit what I think of as a classic seizure.
Yeah.
So if there's a confusion, because seizures can look like any sort of thing. It can look like restless movement during sleep. It can look like anxiety attacks where they run around and jump up and down, right? It can look like all kind of things, but the main thing is this recurrent odd movement.
Mhm.
And we who see seizures all the time, when we see videos, we're going to see details and things that lead us down that path. So when I have a parent who brings us a patient who could be a seizure, but I can't quite tell what they're describing, I don't know exactly what they're seeing. That's when I want the video. A big classic grand mal seizure for a certain amount of time. The video is not as helpful, especially EEGs, everything fits.
Mhm.
But in a confusing case, a questionable case, the video can sometimes seal the deal,
Mhm.
right? So you know you're doing the right thing by giving them medication.
Yeah. Yeah. So why nothing in the mouth?
That's a good question. So commonly on TV, and if you just talk to relatives, they'll say,
Mhm.
put something in so they don't swallow their tongue, right? They don't swallow
Yeah.
their tongue. But what happens when you try to do that is they'll either bite you,
Yeah.
and when you're seizing, you're contracting at max. So you'll lose a finger, you'll or you'll injure the child trying to get something in their mouth because
Mhm.
it's already closed.
Yeah.
So the risk is not swallowing the tongue, it's choking on either saliva, which usually is increased at the time of seizures, right? Drooling, foaming at the mouth.
Mhm.
So you want them on their side so it all just comes out. If
Mhm.
they lay face flat, they can't breathe, and on their back they choke. Because if you see a child having a seizure, they can't manage any of those secretions. So you just have to put them on their side for that purpose.
Okay.
And sometimes they bite their tongue or they bite the side of their mouth, but you can't prevent that with a U. So no utensils because you'll chip their teeth or hurt them, and no finger because you'll get injured too.
Mhm.
So
Even if they are vomiting, that still comes out
correct.
the side.
And most people vomit either at the beginning of a seizure
Mm.
or after one.
Mhm.
When they're confused and coming out of it, they vomit. So it's just good to kind of keep them in this safe ground level position while they're getting out. And these are not true for seizures where you're not convulsing. So if it's a staring seizure, you're just confused. The main treatment for that is keep them safe,
Yeah.
right? You're crossing a road and they have a seizure, get them off the road,
Yeah.
right? Get them into a safe spot, let the seizure happen.
Yeah.
But a convulsive seizure, that is.
And does it matter which side?
They ask me that all the time, and I say no.
Okay.
Although if it's a partial seizure, like one side moves more than the other, I like the side that moves the least to be on the ground
Sure.
for carpet burn purposes, right? Just kind of thinking about that. They can't
Sure.
tell what's happening. So
Yeah.
if you have a side that's the active side, I kind of tend to have
Do
that
the
out.
opposite.
Yeah.
Got it. So let's say my child has had a seizure. I've been to see my pediatrician. They're referring me to a pediatric neurologist. Tell me about how you may work with pediatricians or other neurologists around our network to ensure appropriate care.
So that's morphed over time for me.
Mhm.
Obviously, there's not very many of us, so sometimes the wait list gets a little long. But I have a policy: any doctor from anywhere in the state who has any question can call me anytime.
Mhm.
So it's kind of simple. If you ask for a referral and you're confused, and you just encourage your doctor to reach out to me. I'm available all the time, right? And so what we do in that case is I get the story from the doctor, I get the referral in, I recommend testing, I even recommend medications to them sometimes that I would start, and we work to get you in very quickly,
Mhm.
right? Here, what's happened in Baton Rouge is they're actually ballooning, right? There's a new providers coming here all the time, so their access is going to be very good, and they're going to continue to recruit. But I think they would have the same approach I do, which is give advice to people who need advice when they need it all the time. And also, it I think helps them to know how do we think about seizures too. So then the pediatrician knows for the next patient, what do I do? What needs to happen?
Mhm.
When does it need to happen? So our accessibility is total in terms of physician to physician. For parents, it's harder because we can't talk to them directly all the time because we don't have that relationship yet,
Mhm.
but the doctor can talk to me at any time.
Yeah. And that I think that shows the power of collegiality and network to where physician to physician, you have the best interest of the patient at the forefront and you're doing whatever you can to make sure they're taken care of
That's it. That's ultimately you want to make sure they get the treatment they need when they need it, wherever they are for whatever reason.
as close to home as
Yeah,
you can.
exactly.
Well, thank you so much for being here.
Thanks for having
It
me.
was so interesting. I know that everyone listening will find it as interesting as I did. And thank you for joining us on another episode of Parenting You, where we're with you every step of the way on this amazing journey we call parenting.